Hello everyone, I am Dr. Muthukumaran, Professor of Respiratory Medicine, Chettinad Health and Research Institute. Now we are going to discuss about screening tool for sleep altered breathing disorders. The objectives of this presentation includes understand major types of sleep related breathing disorder, 9 validated screening questionnaires, and differentiate high risk versus low risk patients and practical use in clinics. The prevalence of obstructive sleep apnea. The prevalence is around 1 billion adults in the global level, according to INOSA 2023 and AASM 2021. In India, it's around 13 to 70% of adults have been affected. The majority of patients are undiagnosed. Many cases remain undiagnosed. Estimates up to 80% of OSA cases in the US are undiagnosed. The wide range in prevalence reflects differences in age, obesity, race, and the methodology for diagnosis of obstructive sleep apnea, which includes polysomnogram, West questionnaire, West home testing, and the cutoffs used were include apnea-hypopneic index more than or equal to 15, then more than or equal to 5 with symptomatic or not. Then because many cases are undiagnosed, the burden is far greater than prevalence, and the screening becomes very important. Then next slide. The OSA is a major yet modifiable global health burden. Then it can lead to cardiometabolic consequences like independent risk factors for hypertension, coronary artery disease, stroke, AF, and heart failure. Then promotes insulin resistant dyslipidemia metabolic syndrome. There is increased post-op hypoxemia, arrhythmias, and ICU stay. Then in case of public safety, there is around 2 to 7% of motor vehicle accidents are risk due to daytime somnolence. Then healthcare cost. The untreated OSA triples the cost via cardiovascular admissions and lost productivity. Then cost effective when screened and treated appropriately with CPAP or weight loss. Then key message is OSA is a common, consequential, and correctable. Then early diagnosis by polysomnogram and treatment mitigates symptomatic and economic burden. Then approximately 60 sleep disorders has been identified in 7 categories, which includes insomnias, sleep-related breathing disorders, central disorders of hypersomnolence, circadian rhythm, sleep-wake disorders, parasomnias, sleep-related movement disorders, and other sleep disorders. In that, sleep-related breathing disorders are main categories of sleep-related breathing disorders are obstructive sleep apnea, central sleep apnea, sleep-related hyperventilation syndrome, sleep-related hypoxemic disorder, isolated symptoms, and normal variant. The definition and diagnostic gold standard of OSA. The definition of according to AASM ICSD 2023, OSA is defined as recurrent upper airway obstruction during sleep, which can cause hypoxemia, arousal, and sleep fragmentation. The diagnostic threshold includes AHI more than or equal to 5 plus symptoms. We can diagnose OSA. Then otherwise AHI more than or equal to 15 without patient is asymptomatic, we can diagnose OSA. Then cases of severity include mild, moderate, and severe. Mild is 5 to 14.9, moderate is AHI of 15 to 29.9, and severe if it is more than or equal to 30. Then gold standard investigation for OSA is polysomnography, which is a comprehensive in-lab test recording EEG, airflow, SpO2, respiratory effort, ECG, and EMG, then etc. Enamels sleep staging and distinguishes OSA with central sleep apnea. Remains mandatory for complex, inconclusive, and with patients with comorbid diseases. The home sleep apnea test has a selective role for high pretest probability uncomplicated OSA. If there is no cardiac congestive heart failure, COPD, opioid use, or stroke. It has limited channels which can detect airflow, effort, and SpO2. Must be interpreted by a quality sleep physician. This slide we are going to see about spectrum of sleep-related breathing disorders, where patients can present with snoring or upper airway resistance syndrome or obstructive sleep apnea. The variants of sleep-related breathing disorders includes primary snoring, then upper airway resistance syndrome, OSA or obesity hyperventilation syndrome. Whereas the patient can present as a snoring, repeated arousal, desaturation, or type 2 respiratory failure. Whereas in primary snoring, the patient will present only with snoring. Whereas in upper airway resistance syndrome, the patient will present with snoring and repeated arousal. Whereas in case of OSA, patient will present with snoring, repeated arousal, and desaturation. Whereas obesity hyperventilation syndrome, patient will have all the symptoms of snoring, repeated arousal, desaturation, and can present with type 2 respiratory failure. Then information sources critical for diagnosis includes both the patient and bed panel. Then there should be a detailed patient interview regarding signs, symptoms, and chief complaints, and physical examination of past and present, and a medical history and family history. Then the detailed history about sleep quality, and comorbidities, which can lead to the diagnosis. Detailed sleep history, which includes sleep timing, sleeping habits, sleep quality, and snoring history, then abnormal behavior and during sleep and apneic events. Sleep timings, daytime naps are there or not, then sleeping habits like nocturnal awakenings and nocturnal diaphoresis, and sleep quality, whether patient is feeling refreshed, fatigue or sleepy, and the history of snoring includes, do you think you snore in the night? Snoring is worse while lying on back or on either side, when whether patient is awakens the bed partner, or whether what's on the night you are exhausted and consumed alcohol. Then abnormal behaviors during sleep includes urge to move limbs in early part of the night, and anyone noticed abnormal movements or behavior in the night. Then apneic event, it usually witnessed by the bed partner, observed you transiently stop breathing while you sleep, or you witnessed a silent period with no snoring followed by a loud snort or a body jerk which awakens you. Then have you experienced episodes of choking in the night? Then detailed sleep history, which includes drug history, personal habits, and occupational history and medical history. Drug history includes all medication to be noted with emphasis on sedatives, antidepressant and anxiolytics. Then personal habits, frequency of alcohol or tobacco consumption, history of consumption of tea, coffee, caffeinated drinks. Then occupational history involves job involving a lot of stress, working hours, and job requiring frequent night travels, and make a medical history of heart disease, systemic hypertension, dyslipidemia, thyroid disorder, diabetes, GERD, headaches, epilepsy, CVA, and depression, anxiety, bipolar disorder, asthma, sinusitis, nasal symptom, and facial abnormalities. Is there anything in that? Then next slide is history and patient interview. Nocturnal and diurnal symptoms of OSAs. We have to note nocturnal symptoms includes snoring, witnessed apnea, nocturnal choking, nocturia, or and sleep quality. Then daytime symptoms of excessive daytime sleepiness, lethargy, morning headaches, cognitive deficit like short-term memory or concentration, psychiatric symptoms, systemic complaints like gastroesophageal reflux, hypertension, diabetes. In patients with nocturia, UT and BPA should be ruled out. Physical examination, neck circumference measured at a point 2 cm below the Adam's apple, more than 60 inches in women and more than 70 inches in men. Then body mass index, which should be more than or equal to 30 kg per meter square in case of OSA patients. Then upper airway evaluation, we have to look for any retrogranthia, eye arched palate, macroglossia, tonsillar hypertrophy, enlarged uvula and nasal abnormality. OSA morphologic score is a clinical prediction tool for obstructive sleep apnea that uses physical morphological characteristics to estimate the likelihood of the condition. Key components of morphologic scores is a combination of the following patient characteristics, which includes patient body mass index, neck circumference, malleability score, and sex. Then DES OSA score. This score encompasses the malleability score, thyroid to chin distance, BMI, neck circumference, and gender to predict OSA. The others are the Friedman tongue position scale or waist circumference. OSA morphologic score. How morphology score works? Measurement. Clinicians take physical measures and assess the patient's airway morphology such as neck circumference and the malleability score. And weighting. How morphologic scores work? Measurement. Clinicians take physical measurements and assess the patient's airway morphology, neck circumference and the malleability score. Weighting. These measures are assigned points often based on the categories that are weighted 1, 2 or 3 points or similar schemes. The individual points are summed to create a total score. The prediction. The total score helps predict the probability of an apnea-hypopneic index greater than a certain threshold, indicating the presence or severity of OSA. Then clinical use. It is used for pre-screening. Morphological scores are used as an early and quick way to pre-screen patients for OSA. Then risk assessment. They help identify individuals at increased risk for OSA, especially those with mild, moderate or severe disease. Then simple and unbiased. The morphological nature of the score predicts the simple, potentially unbiased method for OSA reduction. Malleability and modified scores. Purpose. The preoperative airway assessment predicts difficulty in intubation and obstructive sleep apnea risk. Simple bedside visual grading based on visibility of oropharyngeal structures. Then original malleability classification according to 1985, the structures visible are in case of class 1 short palate, uvula and fauces and pillars. In case of class 2, short palate, uvula and fauces will be visible. In case of class 3, short palate and base of uvula. In case of class 4, only hard palate will be visible. Modified malleability classification add a class 0 where epiglottis is visible. Better intra-observable reliability and correlates with the AHI severity in OSA. Assessed in sitting position, neutral head, tongue out and no phonation. Clinical correlation. OSA prediction. Higher malleability class of 3rd to 4 increases moderate to severe OSA according to AASM 2021 and INOSA 2023. Then airway management used with thyromental distance, neck circumference, BMI and stop bank for perioperative screening. Then Mallamati and modified Mallamati scores. Reference values are around sensitivity of 65 to 70% for predicting difficult airway. Specificity is around 60%. Then OSA risk is present in case of class 3 and class 4 around 2 to 3 4-fold rise in AHI more than or equal to 15%. The pictures depicts the class 1 to class 4 of Mallamati scores. Friedman tongue position score is a 4-grade classification system used by physician to assess the oral pharyngeal airway space with higher grades indicating less space and a greater risk for obstructive sleep apnea. Then clinical significance includes sleep apnea screening. The FTP score is a component of a comprehensive screening tool for sleep disorder breathing and sleep apnea. And then correlation with OSA severity. A higher Friedman tongue position score is significantly associated with a higher apnea hypopneic index, which measures the severity of sleep apnea. Then treatment planning. This goes along with other factors like BMI, tonsil size and helps assess risk and design treatment plans for patients with sleep apnea. And then instruction. The patient opens their mouth and rests their tongue on the floor of the mouth without saying ah or sticking their tongue out. Then grade 1 is the uvula and tonsil are completely visible. Grade 2 is that the uvula is visible but the tonsils are not. Then grade 3 is the soft palate is visible but the uvula is not. Grade 4 is only the hard palate is visible, indicating the most restricted airway space. Next slide is about Muller's maneuver and dynamic nasopharyngoscopy. Muller's maneuver is a diagnostic technique to detect airway narrowing. It is performed by attempting to inhale against pinched nose and a closed mouth with a fibrotic nasopharyngoscope in place. The resulting negative inspiratory pressure will cause the valves of the upper airway upper airway to collapse in a narrowed way. It's a positive in case suggestive of obstructive sleep apnea syndrome. H is correlated positively with the Muller's maneuver. Then dynamic nasopharyngoscopy is a flexible scope to examine upper airways to find any obstruction such as DNS or polyps. It demonstrates the dynamic behavior of airways in conditions which promote and prevent collapse. I am repeating the slide. Guidelines which we follow for diagnosing obstructive sleep apneas are INOSA, which is an Indian Institute on Obstructive Sleep Apnea Guidelines, and AASM, which is an American Academy of Sleep Medicine. The role of questionnaires. It's an inexpensive validated screening tool to select patients for polysomnography. Questionnaires are the important screening tool for diagnosing obstructive sleep apnea. The major questionnaires which we use commonly for sleep-related disturbed breathing are Berlin questionnaire, Epworth sleepiness scale, Stop Bank, NOSAS, Gold questionnaire, Stanford sleepiness scale, OSA 50 questionnaire, no apnea score, and pediatric sleep-related breathing disorders. INOSA guidelines recommendation includes ESS. Epworth sleepiness scale is a subjective test that focus solely on excessive daytime sleepiness, and it does not score other signs and symptoms of OSA. It can be used as a tool to measure the quality of life with regards to EDS, likelihood of long-term compliance to CPAP therapy, and to evaluate treatment response rather than only screening test for OSA. Then Berlin. Both Berlin and modified Berlin questions are moderately accurate in the screening for OSA. Then comes the Stop Bank questionnaire. It's a most appropriate questionnaire for the screening in case of preoperative cases. May also be used for pre-test probability assessment before polysomnography because of ease of administration and high sensitivity and specificity. Berlin questionnaire is presented in 1996 in a conference on sleep in primary care. It was modified at AIIMS in New Delhi 2006 for application in the setting of developing countries. It is divided into 3 sections. First category is about snoring, then second category is about daytime fatigue and sleepiness, then third category is about medical history and anthropometric measurements. This is the format of Berlin questionnaire, which includes the basic anthropometric measurements, gender, and category 1, category 2, category 3. Category 1 includes 4 questions regarding snoring, and category 2 is regarding the patient's fatigueness and sleepiness, and category about pressure. Then category 1 includes how patient snoring is, and then how often patient is snoring, and whether it bother other people, and is anyone noticed patient is having sleeping breathlessness during sleeping. And category 2 includes whether patient is feeling tired or fatigued after sleep, and during wake time patient is feeling tired, fatigued, or not up to the par, and if patient is fallen asleep during driving a vehicle, Then if yes means how frequently it occurs, and category 3, which includes patients, whether patient is having high BP, high blood pressure or not. Stop bank questionnaire. Stop questionnaire, which includes S stands for snoring, T stands for tiredness during daytime, then O stands for obstructive apnea, and P stands for high blood pressure. Stop is considered positive when 2 or more are answers are yes. The stop bank questionnaires includes, apart from snoring, tiredness during daytime, observed apnea and high blood pressure. B stands for body mass index, A stands for age, N stands for neck circumference, and G stands for gender. More common in males are relatively easy to administer. Stop bank is positive when 3 or more answers are yes. Then this is the stop bank test. Then each question carries 1. Episode sleepiness scale is first developed in 1980 by Dr. Jones. After Episode Hospital in Melbourne, it has been established in Episode Sleep Center in 1988. Then slight modification has been done in 1997. Then it's a self-administered questionnaire with 8 questions. Usual chance of dozing off or falling asleep in while engaging in the activities to be rated off in 8 different situations that are met in day-to-day life on a scale of 0 to 3. Then multiple studies have shown good correlation of ESS with the level of sleepiness and sleep latency as measured by objective tests such as multiple sleep latency test. Then right, you can see the Epworth sleepiness scale scoring system. That 8 situations includes sitting and reading, watching TV, sitting in a public place, which includes can be a theater or meeting, sitting in a car as a passenger without break, lying down to rest, sitting and talking to someone, sitting quietly after lunch without alcohol, in a car with while stopped for a few minutes in a traffic. Then it can be scored between 0 to 3. If a patient would never dose, it's a 0. Slight chance of dosing means 1. 2 means moderate chance of dosing. High chance of dosing means it's 3. Depending upon that, if a total score is more than 10 means suggest presence of excessive sleepiness. Stanford sleepiness score is a single item self-report questionnaire developed by William C. Dement and colleagues to assess current levels of sleepiness scale on a 1 to 7 scale. Then with 1 indicating alert and wide awake and 7 indicates sleep onset is imminent. Then purpose of this Stanford sleepiness score is measure subjective sleepiness. Then SSS provides a quick and easy way for individuals to rate their own level of sleepiness at a particular moment and track sleepiness over a time and identify sleep debt. The limitation of a studies are it is not a performance measure. Whether while it can be indicate if increased sleepiness after sleep deprivation, the SSS does not reliably predict individual performance on a vigilance or a memory test. Then it's not a clinical tool. Normative clinical has not been established for the scale. Then this is the Stanford sleepiness scores, which rating from 1 to 8. Then 1 means feeling active, alert and wide awake. 2 means functioning at high levels but not fully alert. 3 means awake, relaxed, responsive but not fully alert. 4 means somewhat foggy, let down. 5 means foggy, losing interest, low down. Then 6 means sleepy, woozy and fighting sleep. And then 7 means sleep onset, having dream-like thoughts. 8 means patient will fall asleep. NOSA score. It has components 0 to 17 points. N stands for neck circumference. If neck circumference is more than 40 centimeters, it carries 4 points. And then comes obesity. O stands for obesity, which can be calculated by BMI. BMI is between 25 to less than 30 means carries 3 points. And if BMI more than or equal to 30 means it carries 5 points. And if S stands for snoring, then if a patient had history of snoring means 2 points, and A stands for age. If age is more than 55 means 4 points, and S sex, gender, and then if gender is male, it carries 2 points, and then cutoff value is 8. More than or equal to 8, patient is having high risk for OSA. Then evidence where it's this NOSA score has been validated in Luzon population study. It carries high specificity compared to stop bank but slightly lower sensitivity. It's good for primary care and epidemiologic screening. Then next is gold questionnaire. Each item carries 1 point. First, G stands for gender, male. Then O for obesity, BMI more than or equal to 30 kg per meter square. A stands for age, more than or equal to 50 years. L stands for loud snoring. Then score 0 to 4, more than or equal to 2, carries high risk for OSA. Then evidence validated in hospital and community OSA cohorts, comparable accuracy to stop bank and NOSA's, simple binary tool for rapid screening. Next is OC 50 questionnaire and no apnea and other sort tools. Then OC 50 questionnaires consists of items. O stands for obesity, waist more than 1 or 2 centimeter in men and more than 88 centimeter in women, carries 3 points. S stands for snoring. Then if a patient is having loud frequent snoring, the carries 3 points. A stands for apnea, means witness stops breathing, means it carries 2 points. And 50 stands for age, more than or equal to 50 age means 2 points. Then cutoff value is more than or equal to 5, carries a high risk of OSA. Then evidences are developed for primary care triage in Australia. It carries high sensitivity for moderate to severe OSA with the AHA of more than or equal to 15, integrates into general practitioner practice questionnaires. Then no apnea and the other sort tools. No apnea score is uses age plus neck circumference to predict OSA. Each factor weighted and a simple chart lookup. Cutoff value is more than or equal to 3, carries high risk for moderate to severe OSA. The use and other salt tools includes age, BMI and snoring variants used in busy clinics, and PAC checklist or epidemiological service, excellent for triage when full stop bank is impractical. Next, we are going to discuss about OSA 18 quality of life questionnaire. It consists of 18 items of quality of life assessment tool for children with suspected OSA. It contains 5 domains, which includes sleep disturbance, physical suffering, emotional distress, daytime function, and caregiver concern. Then scoring includes each item between 1 to 7 with a total score between 18 to 126, with less than 60 means mild impact, 60 to 80 is moderate impact, more than 80 is severe impact. It can be used as a quantifies disease impact and treatment benefit, especially after adenotonsillectomy, and can be used in ENT, pediatric pulmonology and outcome research. Then we can use overnight pulse oximetry in case of children. Then it's basically home or hospital overnight oximetry measuring SpO2 drops during sleep. We can use McGill oximetry score classify based on desaturation clusters. McGill scoring is it's a score based 1 to 4 based on more than or equal to 3 desaturation clusters. It carries high specificity. If it's more than or equal to 2, it carries high specificity for moderate to severe OSA. Then it can be used when polysomnography is not available, especially in resource limited or remote pediatric setting. It can guides ENT triage for adenotonsillectomy or referral for polysomnography, and carries high specificity for moderate to severe OSA, lower sensitivity for mild cases. ASM acceptable screening for prioritization tool, not a diagnostic replacement. This is the questionnaire for OSA 18 quality of life survey, which carries 5 domains, which includes sleep disturbance, physical suffering, emotional distress, daytime problems and caregiver concerns. Then it validates points, each question valid between 1 to 7 from none of the time to all of the time. And then with the scoring of each between 18 to 126, see this has been explained already, with less than 60 mildly impact, 60 to 80 moderate impact, more than 80 severe impact. Basically in this slide we are going to compare the various questionnaires. Basically the target population is adults in case of Star Bank, Berlin questionnaire and ESS, and in case of children we can use pediatric sleep questionnaire or 6 or 8 item scale questionnaire or pediatric sleep survey instrument. And then come to sensitivity, specificity and performance. Star Bank is a widely used good sensitivity in moderate to severe OSA and carries low specificity. And Berlin questionnaire carries moderate performance in many studies. And ESS can be useful as a adjunct. Then pediatric sleep questionnaire, in one study STB subscale cutoff of 5 gave sensitivity of 0.94 and specificity of 0.76. Then in ages between 5 to 10. Then 6 item scale sensitivity is 70%, specificity 95%. Then 8 item if sleepy sensitivity is 82% and specificity is 28%, children more than or equal to 7 years. Then we can use as SwayamPrabha as a simple, but many false positives are there. Then Berlin questionnaire does not substitute for objective testing. Then pediatric sleep questionnaire is good for screening, but diagnostic requires polysomnogram. Then 6 item scale or 8 item scale questionnaire, trade-off between sensitivity and specificity may generate many false positives. Then pediatric sleep survey instrument is a good screening tool in general pediatric populations. This slide we are going to discuss about the flow chart for clinical suspicion of OSA patient. Whether patient is having signs and symptoms that indicate increased risk of moderate to severe OSA, yes. Then patients having any comorbidities like cardiopulmonary disease or neuromuscular conditions, or patient having awake ventilation or high risk of sleep-related hyperventilation, or personal environmental or personal factors that preclude the adequate acquisition and interpretation of data from home sleep apnea test using the screening tool. If a patient is having yes, perform PAC by sleep center by under the supervision of board certified sleep physician and follow a split night protocol if clinically appropriate and feasible. Then if it is if yes means positive diagnosis and adequate results made, sincere treatment for OSA. If no, perform home sleep apnea test administered by accredited sleep center under the supervision of board certified sleep physician. If it's a positive diagnosis and adequate results made, we have to initiate treatment for OSA. If no means we have to evaluate for other sleep disorders or perform polysomnography when OIC has not yet been ruled out, and it has been followed by split night protocol. Post diagnosis and adequate results made, we have to start treatment for OIC. If no means we have to evaluate for other sleep disorders and repeat in lab polysomnography. The high yield points in this topic was episode sleepiness scale can be normal even despite severe OSA. Then stop bank and favors high sensitivity can be used as a good for pre-op patients. Then anthropometric cutoffs like BMI, neck circumference need local calibrations. Asians have OSA at a lower BMI. Then home sleep apnea test is not suitable for children suspected central apnea or significant cardiopulmonary disease. Thank you for patiently listening.